Hello, everybody. I want to welcome you to today's podcast episode. Today, we are talking to Dr. Neil Bhattacharya. Dr. Bhattacharya is an associate professor at the University of Florida. He is the director of the residency program for oral pathology. I've heard you lecture several times, probably half a dozen times. I'm always intrigued. You're always present great information. And when I came up with a topic of oral lesions, oral sores, oral ulcers, I'm very glad you're on here. I know you did your training in Indiana, and you're a huge Colts fan, and Pacers and all sorts of basketball fans. So big basketball country over there. So Dr. Bhattacharya, thank you so much for being here. I'm just going to get started. Our biggest mouth sore that I see on a day in and day out basis is the classic canker sore, is what they call it, also known as an aphthous ulcer. So tell people that are watching this, what is it? Why it comes there, and how people should treat it?
Sure thing. Canker sores, as you mentioned, is one of the most common type of oral sore. In fact, there are some estimates which say almost 20% of the world population. So you can imagine how many. That is enormous. That's close to 2 million to 5 million people on a daily basis get canker sores just in the United States. So it's an enormously common problem. People deal with it most of the time because they know these are transient sores. And lots of our patients ask us, why am I getting canker sores? The reason is it's an autoimmune disease. It's not something you've eaten. It's not something you've done to yourself. It's not something that you can get or transmit to people over time. It is purely it's an autoimmune disease, just like you have arthritis or you have lupus or several others, thyroiditis, etc. It's an autoimmune disease, and it's possibly genetically transmitted. So parents who get canker sores, often their children will get canker sores. Some of the other things that can trigger canker sores are stress. So if you're very stressed, typically, if you haven't slept well, if you've been under a lot of job-related or personal, mental, physical stress, you can break out. And when I say break out, typically where do canker sores occur? They occur on soft tissue. Soft tissue in the sense, not on the roof of your mouth, which is tightly bound down. It is mostly the looser tissue. So under your tongue, sides of your tongue, tip of your tongue, cheeks, inside of your lower lips, or all the way back on the soft palate or on the top of the tonsils. And we tend to divide canker sores into major and minor. Minor are the ones that are a little smaller, and they're typically seen, just as a rule of thumb, toward the front of the mouth. And major are seen in the back of the mouth, and those really are a major pain. They are very painful. I know patients who have lost 20 pounds of weight in 1 month because they could not eat or even drink a supplement, a nutritional supplement. So these can be a big pain. Typically, again, young people get it. However, we see it across the age groups. I've seen patients who are 66, 67 years of age who get canker sores. There are people like myself who get one maybe in 5 years, or my son who gets one every 2-3 months, but not that painful. We can manage it with some topical ointments available over the counter, such as Andesol, Canker. There's several, or base with benzocaine. You can go to your dentist and ask them to write you a viscous xylocaine if you get once in a while. However, there are other patients I know who are never free of one. So they get 4 or 5, get better. Before the last one's better, they have another crop. And these individuals are in severe discomfort because of these. And for those patients, we have to give them either topical steroids, or you have to put systemic steroids, which has other, many major side effects of putting patients on steroids. There are some very good papers out these days that say omega-3 fatty acids, so basically fish oil, taken at high doses. And you might say, what is high dose? Generally about 6,000 milligrams a day, so double the recommended sort of dose. Take it for a month. It has shown to be useful. There are some other studies which have looked at an anti-gout medication called colchicine, which can be tried, but the problem with colchicine is it can cause stomach upsets and GI problems. So you have to be careful, talk to your dentist or your physician before you just don't plan to start something like that. You need to be evaluated well. Canker sores are not something to be afraid of, though. Most dentists who are trained well, I know our University of Florida graduates all know about topical steroids. They can write you a topical steroid, your patient a topical steroid prescription, and you apply it with a Q-tip or your finger, typically 2 to 3 times a day, and you'll notice the sores fade away. And then they may come back depending on, again, your life stressors.
What's the most common topical steroid you're prescribing? What's kind of the high on your list?
The one we prescribe the most is it's called, the medical name is fluocinolone. The trade name often sold under is called Lidex, Lidex. And this is available both as a cream or an ointment or a gel. The other one, which is a step higher or more potent, and I personally prefer this, is called clobetasol. Clobetasol is sold as ultravate or temovate, and clobetasol is pretty powerful. It's available again as a cream, ointment, or gel. And then some people, when they get hundreds of sores, or maybe less than 100, let's say they get 10 or 12 sores all over the mouth, there are rinses available. The classic one is Decadron Elixir, which is dexamethasone, and they can take a teaspoon, swish around in the mouth, but these are all prescription drugs.
Okay. So this is if somebody's watching this and they're looking for their dentist to give them something. Absolutely. These are the ones that you currently, at least as of today. There was a study I just read about. I don't know if you've heard anything about this. It's out of Saudi Arabia, where they coated their canker sores with honey. This is for people out there that like to have, organic or homeopathic type relief. Right. And it said that the sores healed either as fast or faster than with steroids. Have you heard of that? I mean, honey, that's
absolutely. There is the active ingredient in honey, which most people believe works, is actually a pretty miraculous drug if we can isolate it. It's called propolis, and a lot of people have done work on propolis. It is a product that is generated by the honeybee, and propolis or honey can be applied directly to all kinds of sores. You can apply it to wounds on your skin, you can apply it to wounds in your mouth, you can apply it to other kinds of oral diseases, not just canker sores. But the problem is we don't have very good blinded studies where we have compared this product matched against. So this is one of the few. There are a few other. If you search on the web, you might find other studies that have, and you have to maybe get away from using the word honey and use propolis, which is
find it.
Propolis is the active ingredient. But most people, again, it's the same skepticism against herbal medications because not everything works well for. And I'm not retracting away from it, but I don't. I'm not a proponent of that because I've seen how well steroids work when patients are in severe pain and are discomfort. But for most people, casual canker sore sufferers, what do I mean by casual? They get one a month or a couple of sores a month, or so many months. Honey is great. If they can find a good quality honey, but not again for children. Remember, for children, honey is often contraindicated. Check with your physician.
So I take it honeybees don't have to worry about getting canker sores, probably, right?
That's right.
Okay, so the next second biggest one I see, and there's a lot of I find misinformation out there, is the common cold sore or herpes. There was above the belt. From when I was growing up, it was above the belt, below the belt. I think new research suggests it's all the same thing. So again, I'm somebody watching this video and I have a cold sore, fever blister, whatever you want to call it, herpes labialis, I think the technical term. Tell us a little bit of background of what the virus is, how do we get it, who has it? I mean, does everybody have it? Obviously, clearly not everybody has it. And some of the issues with the above the belt, below the belt, and then, of course, current treatments.
Right. So that's a very, very important point. I think very important for not only dental professionals to know, but for most patients to know, is cold sores or herpetic sores are very, very different from canker sores. One of the biggest differences is cold sores or herpetic sores. I'm going to use the word herpetic sores here, and later you'll find I'll distinguish them between herpes simplex versus non-herpes simplex.
Sure.
Herpes simplex is a virus that is unfortunately the only reservoir known. Humans are the only known reservoir, so nobody else. You can't have very many experimental animals getting infected with herpes, and therefore, unfortunately, research gets limited because you only have human subjects that
Sure.
you can try out medications on.
Sure.
There are some mice that you can create herpetic sores on or infect with. That is one of the bigger problems. However, there is HSV-1 or herpes simplex 1, which causes oral sores. However, does that mean you can't get it below the belt? It's possible to get HSV-1 below the belt. You also have HSV-2, which is the genital herpes. Same family, just one small difference in the protein structure, and these are seen typically in the external genitalia in both men and women, and these, can they affect the mouth? Yes, but do we see them in the mouth? No. You have to have orogenital contact and open areas of infection in the mouth before you can establish that.
Sure.
Now, would the lesions look different between the two? Not really. They look the same. So where in the mouth does herpetic sores occur? Typically on bound down tissue. So anything that is tougher, top of the tongue, which is tougher, roof of the mouth, or your attached gums, which is the gums that are tightly bound down, sort of the shiny part of the gums.
Sure.
And of course the outside of the body, which is outside of the lips, which we call mostly fever blisters, cold sore, herpes labialis. You can get people who wrestle, kids and young men and women who do that often get them on the elbows, behind their knees, which is called herpes gladiatorum, which comes from, again, skin to skin contact. It is spread by contact. So somebody has a cold sore, whether it's your patient or the physician or the doctor, they should not typically be treating patients. Don't go kissing children, because you can transmit the virus.
Sure.
Once the sore breaks open, the blister breaks, and if crosses over, it's no longer infective. At that stage, you're okay. You can treat the patient, deliver a crown, do scaling and root planing, get dental treatment. And the other warning to dentists is, if you have an active patient, can you defer a delivery of a crown? Absolutely. Take 5 days. Call them back 5 days later. Give them something to tide over the pain and discomfort. And that's when we come to treatment of it. The typical treatment is acyclovir. Acyclovir is generically available. It's very cheap. I think even without prescription coverage, most people would be able to afford a whole course of acyclovir.
Okay. Yeah.
And doses can be different, but you can give it to children all the way with syrup, or you can give it in form of tablets to adults and older. And you also have what I prefer is valcyclovir. This is a newer drug which was first approved for genital herpes or HSV-2, but now has been approved by FDA for prophylaxis as well as treatment of herpes simplex 1, HSV-1, which is oral herpes. And typically the dose is anywhere from 500 to 1,000 milligrams to 2,000 milligrams a day. And you can just give it 2 times or 3 times, which is 3 days or 4 days. If it's a very severe infection, you can go all the way up to 7 days. And how can we distinguish? So herpes simplex also has 2 kinds of infection. One is called primary infection, which is when children typically get it or young adults get it. It's spread all over the whole mouth, lips, gums, tongue, cheek, no surface bound down, non-bound down, everything.
Lots of discomfort there. I've seen those kids. They are hurting. Fever.
They have swollen lymph nodes. Children refuse to eat or drink because it's very sore. It lasts anywhere from 7 to 10 days, and then the lesions get better. Without treatment, they'll get better because the virus goes back into the nerve ganglion, travels along the nerves. So typically when people who get cold sores, the secondary kind, or this was primary, secondary kind, is they'll get one or two sores, typically after dental treatment. They haven't slept well, they've consumed too much alcohol. Any of those things that can lower your immune system will trigger the virus to travel out of the nerve and affect a particular part of the skin. Typically, we are talking about the oral cavity or perioral region. It'll affect anywhere in this region. That particular nerve supplying, let's say, the skin of the upper lip, and you'll get a sore on the upper lip. And you can actually feel a tingling or a burning sensation, or a numbness, or a unusual, many patients will say it's a weird sensation. We call it, in scientific language, prodromal sign. And prodrome comes typically with herpetic lesions. And again, if somebody gets them frequently, that's when we treat them. Otherwise, we tell them, look, just put Vaseline, Aquaphor, anything over-the-counter, chapstick, just cover it up with Vaseline so it's not always affected. Don't share your chapstick. Don't touch surfaces. If you've drank from a cup, put the cup away or wash it off right away. Wash your hands with soap so that you don't infect other people. In dental offices, the transmission is much lesser, in spite of what people think, because dentists and their assistants are almost always wearing gloves, and we are changing gloves between procedures. So chances of transmitting this. However, when you're using a high-speed handpiece and somebody has a cold sore, you can actually aerosolize the virus, because it's coming in the area of contact, and then the spray gets there. So it's better to wear eye protection. That's why we have our patients wear eye protection, our assistants, and we ourselves wear a face shield.
Or probably common sense, if you're a dentist or you're a patient, just defer appointments. And then, you said something interesting. So 2 points I just want to bring home. You said something about how it's not contagious after it crusts over. So if you see like a shell crust over it, now it's healing. And
that's just a sore with a scab on it, just like any other sores on the body. Like you've fallen down, got a scab on your body. That's the same thing. You don't have to treat it. You don't have to.
It's over. It's just healing. So now the other thing so this virus lives in the nerve. You said it travels back up. So what? The virus actually lives in one of the nerves in your mouth?
Absolutely. Not just our nerves. It also lives. It can be anywhere in our body, but typically, since we are talking about oral herpes or HPV-1, it lives in the head and neck nerve system. Very, very similar to the herpes zoster virus, which is actually the chicken pox virus. But fortunately for humans, that virus gets activated in a much smaller group of people. Not everybody gets shingles. I mean, fortunately, for example, I got shingles back 4 years ago, and it's a pretty devastatingly painful condition. Those who have had shingles will know it travels from one nerve system and then infects that particular area. It's also contagious, but not as contagious as cold sores, fortunately, because people have had chickenpox. If you've had chickenpox as a child, you're immune to it. But for older adults, that's why we advise taking a zoster or shingles vaccine. Patients over the age of 50 to 60 should be taking a vaccine to prevent them getting shingles. And shingles can affect the mouth, by the way, and very severely so.
So next topic, and this is a big topic, and we already discussed it. I think we just have to hit some highlights because we could go on all day about this. I think I heard you lecture for 2 days on oral cancer, but it's a big buzzword out there. Obviously, you hear it often enough. I think it's the 9th leading cancer out there. It's a pretty big player out there. So to anybody who's watching this or trying to learn about oral cancer, who are highest at risk? What age group? Males, females, and then what kind of social habits need to be more cautious? And then as a patient, if a patient watching this, what not to ignore? I mean, clearly it's never possible to diagnose or everything like that without biopsy, and that's kind of what you do all the time. But if you were just giving general advice, what should somebody watching this video not ignore?
So one of the biggest things we tell almost everybody, and for somebody who's watching it such as a patient, I would say never ignore a sore that has been there for more than 4 to 6 weeks. No matter whether you think it's a cold sore, fine. It could be a cold sore that is a little unusual and has lasted 4 to 6 weeks. If it's a canker sore, it should not last 4 to 6 weeks. The other thing I tell people is if it's in a high-risk location, and what do we mean in pathology by high-risk location?
Yeah.
As most of our dentists in this country are familiar with, is the sides of the tongue, bottom of the tongue, the floor of your mouth, which is the surface, sort of the soft hammock below your tongue, soft palate. These are the high-risk spots. You should not have a sore there. Let's say you've eaten a potato chip and it's poked you in the roof of your mouth or on the floor of your mouth and created a sore. You know you hit yourself. It should disappear within 4 to 5 days. You maybe did some warm salt water rinses or maybe used a mouthwash and it went away. That's great. However, if it doesn't go away and you do remember biting, that may be just a coincidence. Any sore that has lasted for more than 4 to 6 weeks should be looked at by a professional. And that professional could be all the way from a dental hygienist, of course your dentist, or an oral healthcare specialist, above dentists, such as, somebody with specialty training, surgeon, pathologist, even a general physician. If you don't have access to anyone or you trust your physician more, just go to your physician and tell them I have a sore, looks like it's been there for 4 to 6 weeks, should you be doing something? And they can usually give you guidelines. Some of the other important things, not always, again, there's no absolute here, but if it's painless, that's a bad sign. If you have a sore on your tongue, and somebody, your dentist or dental hygienist has seen a sore on your tongue and they've touched it and you tell them, no, it doesn't bother me. That's not a good sign, because most traumatic sores, let's say you've bitten on your tongue and created a sore, or you have a canker sore, these are excruciatingly painful, let alone non-painful. The difference is so vast, it's like having one where there's almost no pain to 10 being very painful. Most canker sores, herpetic sores, traumatic sores are close to 7, 8 is what general patients say, sometimes even 10, whereas cancers, unfortunately, are close to 0 to 1. There are hardly any symptoms. By the time they show symptoms, it's usually very advanced, which means it has penetrated into nerves and now they're chewing on the nerves essentially, or muscle, which is what is causing pain. And other than that, I do want to say, you had mentioned about habit. So that was the traditional role. We knew tobacco, alcohol, especially the combination of the two was the worst. And it's dose related. So somebody who smokes 2 packs a day, drinks 2 beers a day, has a higher risk than somebody who smokes 7 cigarettes a day and has alcohol a day, or somebody who smokes 8 pack a day but drinks a 6 pack a day. So you can see it's dose related. It's a dose dependent process. Unfortunately, more and more and more we are becoming aware of another entry that you could say in this business really, which we didn't notice before, is human papilloma virus that has started to cause quite a few oral and especially oropharyngeal carcinoma, so back in the throat area. And this affects young urban males. For some reason, young urban males, cities like New York, San Francisco, Los Angeles, Chicago, we are noticing a huge increase in young males, and most of these are well-to-do with jobs and with income, enough nutrition. So I'm not just saying monetarily, but they have enough.
They're generally healthy people. Like that was what Michael Douglas got, right?
And it is transmitted by sexual contact. And most studies have established 6 or more partners over the course of somebody's life puts them at a higher risk, and which is why the new vaccine, which is Gardasil, given to young men and women less than 13 years of age, is considered to be very effective in blocking this virus. Now, having said all that, somebody with the cancer caused by the virus is by far much more favorable in terms of how they're going to do and live and how much tissue will they lose from surgery or will radiation work. Everything is better for a person with a virus-induced cancer than a non-virus-induced cancer. So tobacco-related cancers, or I should in using scientific term, a carcinogen-related cancer is far worse in prognosis than the HPV-related cancer, which has much better prognosis.
The HPV one, was that not what Michael Douglas battled a few years ago, made a lot of headlines? Or
Michael Douglas is one who made that very well known. Most of the
lots of people ask me about it. Yes, it is true.
That is the kind. Most of us, again, researchers have looked at swabs from thousands of people, and they have found almost all males and females have HPV in our system. We already have it. It's pre-existing because we've been exposed to it through our lifetime. And that is why when we see suddenly a cancer in a 65-year-old male who's retired, who's now playing golf, healthy, has good nutrition and immune status, suddenly gets a carcinoma in the back of his tongue, and we test it by HPV and it's positive, we start to say, maybe he was sexually active. No, it was this virus that was probably living in the area, for some reason got activated. We don't know what those reasons are. We still haven't established that. We don't understand it. But fortunately, I can tell you, oral cancers remain a disease of older folks. It is not young people who get this cancer to date. And unfortunately, smoking or drinking may not be in their lifestyle, but people are always open to getting a cancer. They're vulnerable to it. We don't know why that happens. And all people can do, especially citizens, normal, non-medical people, your patients, should be aware of a sore that does not heal. Don't take sores that do not heal. Take them very seriously. Show them to your dentist. Most dentists who practice in Florida, licensed in Florida, are very well trained. I mean, they know what to do, immediately refer you for a biopsy. And by the way, that is the only way to diagnose it.
Yeah, that is kind of interesting. A little bit of a selfish question, because I want to know, because last time I heard you lecture about the diagnosis, clearly, yes, I do know. I mean, so the take-home message for somebody watching this: 4 to 6 weeks, non-healing lesion, get somewhere. Now, from a clinician's point of view, and certainly I know as a patient, there's different ways of doing the exam, oral cancer exam. For me, I was taught with a cotton. I'm looking visually. I have my loops, my light, and I'm palpating, and I'm kind of doing the traditional exam. There is a veloscope. There's Visalite. There's these brush biopsies. Any strong evidence that there's something new out there, some camera, some dye, anything like that that's superior or making ground. Meaning, if I'm a patient and I'm concerned, should I look for a dentist with one of these, or what are your thoughts on that?
That's a very, very good question, Ramsey. And there are machines out there. Unfortunately, one of your questions was, is there evidence that it helps? And unfortunately, to date, there is not a single device out there that gives you greater power to detect something that's occult, which is hiding in there, in your mouth. There is none. You may get lucky with your Wellscope. You may get lucky with your Visalite, which is dye, toluidine blue dye, treated the patient with vinegar, which is acetic acid, and then shine a light on it. The theory is it should highlight areas which are atypical. The problem, the scientific issue behind the problems we are facing with these devices, all of them work to a certain extent, but the problem is, if you have in cancer, and I'm going a little bit more into depth of molecular biology, in cancers what happens is tissue turns, so cells are multiplying faster. There are several oral conditions where tissue multiplies faster. For example, if I chew on my cheeks, if somebody habitually chews on their cheek, what you're doing is turning tissue over faster. You chew, so it sheds off, new tissue forms. Geographic tongue, tissue turns over very fast. It's somewhat like the psoriasis of the mouth, lichen planus. It's another autoimmune disease which can turn over tissue faster because the tissue is getting attacked by our own body's lymphocytes.
Yeah, not cancer, but yeah.
And these are absolutely benign conditions. Now what you do is you shine a light, these look positive. You can say, I'm helping my patient, but you're also unnecessarily creating stress, so like you, I prefer to use a good quality light, a mirror and a piece of gauze, so that I can look through, lift the tongue up. So for dentists, I would say, if you've examined the tongue thoroughly, the floor of the mouth, you've already ruled out 85% of chances of finding a cancer. And then you take a good quality loop light or a good quality chair light, and you look in the back of their mouth, ask them to say ah, and you don't notice any abnormal red or a growth or a sore. You've ruled out almost 100% chances of finding cancer. Yeah. There are a handful of cancers on the gums that can mimic periodontal disease, but they're rare. You can get cancer on the roof of your mouth, but it's extremely rare. But then when somebody tells me, so I stratify my examination. Somebody tells me I have, I'm a smoker. I've smoked for 30 years, recently I do a better job in their mouth than somebody who's a I will look more just to make sure that there's nothing I find, a patch, white patch, not just a sore. See, cancers can be a thick white patch sometimes, which we call leukoplakia. We try to rule those kind of things out. If they have a big wart-like, like a papilloma-like growth on the back of their mouth, and they are 65 years old, they used to be a smoker maybe 20 years ago, but they were a heavy smoker when I do a better job of examining those patients, whether I have a light or not. But if you do have one of these devices, you're not gaining much more than doing a thorough oral exam with a good open light and mirror and a gauze.
Sure. So last question, I really appreciate it. We could go on all day. I could have 10 episodes just with you, and hopefully there'll be more episodes. I know you're the director of the residency, University of Florida, one of the best residencies for oral pathology in the nation. So my question, I also know you're a big Colts fan. So if Andrew Luck decides to stop being one of the best quarterbacks in the nation, would you let him become, do you think he'd make a good oral pathologist if he decides to quit the NFL tomorrow?
If he goes into dental school, absolutely. I think he will be the best.
I think so.
Maybe we should put him in Jacksonville.
Yeah, I'm not sure if he's going to give up his job with the Colts. I think he's clearly proving himself to be one heck of a quarterback. But if he's watching this video, it's good to know that you think he could make a good oral pathologist should he decide to make a change.
Absolutely, absolutely.
Dr. Bhattacharya, thank you so much. Again, I really appreciate your time. And for everybody watching, I hope you enjoyed it. Please place your comments on our YouTube channel. We'll do our best to reply or get any kind of feedback. But I think this is very informative. A lot of people need this information. Thank you.
Thank you, Ramsey. It was great talking to you guys.